Welcoming our next amazing speaker, Howard, please.
Thank you. When I finished medical school, I was pretty excited. Now I'm going to help people recover from illnesses. But frankly, at the same time, I was terrified that I would mess up. Fortunately, the terror lessens over time. And a lot of people do recover from illnesses. But on the other hand, we know that there's categories of people for whom recovery just isn't in the cards. And that's devastating for patients and their families. And it's hard on us too. About 15 years ago, I was in a practice that I thought I would be in for the rest of my career. And then a book changed everything. It led me to start a practice in a completely different area of medicine for me. And suddenly I was working with a whole category of patients for whom we all knew were unlikely to recover because they had a seemingly insolvable problem. And this problem is now a full-fledged epidemic in our country, affecting more people than cancer, diabetes, and heart disease combined. Millions of people are suffering. Amanda was one of those people. When I met her, she was a 35-year-old married woman. Her diagnosis was chronic pain. About 3 years earlier, Amanda was at work and she bent over to pick up a small box. And as she straightened up, she got a sharp, severe pain in her lower back. And it just didn't go away for weeks and then months. Amanda went to her doctor and she was referred to other doctors. She had 3 full separate courses of physical therapy. She was put on pain pills and then nerve pills and even antidepressants. And the only thing that happened was her pain actually got worse over time. And she developed a new pain in the middle part of her back. Amanda tried acupuncture and yoga, chiropractic and massage. She even got injections in her back, which helped for a week or so, and then the pain came back with a vengeance. Amanda's MRI showed in the lumbar area 2 degenerative discs and a bulging disc. But in her thoracic region, where she also had pain, it was completely normal. Amanda was referred to the office of a very respected spine surgeon, and she recalls him telling her this: "You've got a badly damaged back. It's probably genetic. But I can't help you. Surgery is not indicated. However, you should expect to live the rest of your life in pain, and you should consider never having children." Amanda recalls sobbing in the doctor's office, feeling that she clearly had run out of hope. In 2003, a medical colleague of mine called me into his office and he said, "Howard, I want you to read this book." It was by Dr. John Sarno. A friend of his had had dramatic recovery from pain after reading this book. And I said, "Okay, I'll read it." Dr. Sarno had figured out from his practice that many people, not all, but many people with back pain and other pains actually had pain due to stress and emotions rather than structural abnormalities. And that frankly seemed odd. But as I read the book, it seemed like an idea that was completely counterintuitive became kind of obvious, and it made sense to me. I called Dr. Sarno. I ended up working with him in his office for a while. And that experience led me to read way more neuroscience research than I ever thought possible. What I learned about pain was simply shocking. A few years ago, a friend of mine was alone at a construction site, and he accidentally shot a nail right into his hand. Looks pretty painful, right? I told you it was shocking what I learned. Surprisingly, he had no pain at all. No pain. When we get an injury, our brain has to make a split-second decision about the importance or the significance of the input it's getting from our body. Apparently, his brain decided it was more important for him to drive himself to the hospital than to be alone in pain at a construction site. And so his brain, therefore, didn't activate what we commonly refer to as the danger alarm mechanism, which causes all pain. If the danger alarm mechanism isn't activated, there will be no pain. And think about a child who falls on a playground. His brain has a million bits of information it has to process and decide, am I hurt or not? Should I cry or not? These are not conscious processes. And so some kids get up and go on, and some kids hang there and cry, and some kids wait until their mother comes running to see if they should cry or not. This guy was written up in the British Medical Journal. He jumped off a scaffolding and impaled his foot onto a nail, piercing all the way through his boot. He screamed in pain. They rushed him to the hospital. And when he got there, they hurriedly removed his boot, and the nail was right between his toes. There was no injury at all. Also shocking, his brain had turned on the danger alarm mechanism and caused real physical pain as a warning signal, but it was mistaken about the risk. I met a doctor a few years ago who was in the Vietnam War, and one day his company got ambushed. He got shrapnel wound to his leg. He had a significant pain, and he was medevaced out. He returned home stateside. His injuries healed, as all injuries do. His brain turned off the danger alarm mechanism, and he was fine, pain-free. Almost 20 years later, he was walking down the street. He heard the sound of a helicopter buzzing up from behind, and at that moment, he got the flash of pain that he had had all those years ago in Vietnam. How do we know how to snap our fingers, how to ride a bike, how to do silly kind of hand-eye coordination things like that? These things are all possible because millions of brain cells connect themselves into neural circuits or neural pathways for specific purposes. This Vietnam War veteran's brain learned pain as a neural pathway. It remembered it all those years, and then it activated it at the sound of a helicopter. We used to think that all pain was due to physical injury in the body, and that was simply reflected in the brain. But we now know that our brains actually generate all of our internal experiences, including pain. If our brain thinks something should hurt, it will construct the experience of pain. And the experience of pain varies from slightly annoying to excruciating. And the more one has pain and the more severe it is, the more likely it is that the pain itself will further activate this danger alarm mechanism, which can lead to a vicious cycle of pain leading to fear, leading to more pain. And this process explains why many people with chronic pain simply get worse over time, and their pain often spreads to different regions within their body. The more you practice a neural pathway, the better you get at it. But you really don't want your brain practicing pain. And I say that phrase, your brain, specifically because it's important to understand that these processes happening in the brain are completely outside of our conscious awareness. When I evaluated Amanda in my office, I examined her, listened to her story, and looked at her images. The injury she had from twisting her back certainly had healed a long time ago, and there was no evidence of nerve damage or anything serious. There were two things striking about her story. One was, of course, she had pain in the middle part of her back where the MRI was completely normal. How to explain that? And secondly, Amanda told me that her pain frequently shifted from her mid-back to her lower back, and then back again. And structural pain doesn't really operate that way. I guessed that Amanda's pain was due to neural pathways in her brain. But there was one problem with this, right? What about her MRI? Wasn't that clearly abnormal? We now have a ton of data showing that if you take a population of healthy, pain-free 30-year-olds and you give them all MRIs, fully 50% of those MRIs will show degenerative discs. And 40% will have bulging discs with no pain at all. And those figures in pain-free 50-year-olds are 80% and 60%. And go even higher from there. The vast majority of adults have abnormal MRIs that are not the cause of any pain at all. It's a misconception to think that an MRI will always accurately indicate the cause of back pain. Which leads me to a second misconception, and that is that neural pathway or brain-induced pain is rare. It's not. Studies show that approximately 85% of people with chronic neck and back pain do not have a clearly identifiable structural cause for their pain. And that number is at least 95% for people with tension headaches and migraine headaches, and even higher for those with irritable bowel syndrome, fibromyalgia, and many chronic pelvic pain syndromes. Which leads me to the third misconception, and that is that neural pathway or brain-induced pain isn't real. This is what I hear all the time, as you might imagine. Doctor, not in the honorific sense, doctor, are you saying my pain's not real? It's in my head, I'm imagining it? That I have a mental condition, that I'm to blame for it? And nothing could be further from the truth. Amanda's pain was 100% real, and certainly not her fault. It's a function of how our brains operate. It's a function of being human. The bottom line is that pain is a message that our brain is giving us, and it's up to us to decode that message. The message might be, buddy, you fell on your wrist, you have a fracture, and you need a cast. But the message might be something completely different. A few years ago, I met a woman who had pain in her butt cheek, right about here. And I asked her, well, when did it start? And she said, right about the time my husband retired. And you know what? That's a very different kind of message. And I realized that these processes had happened to me at several points in my life. In fact, on the first day of my internship, you may recall I was a terrified young doctor. And on that day, I got the runs, diarrhea, and it lasted for about 6 months. I didn't have an infection. Something about being a doctor simply scared the crap out of me. And that's the truth. This is Kelly in her senior high school picture. When Kelly was 15, she suffered a severely upsetting emotional event. And within days, she got a pain right in the back of her head. And it persisted for months and then years. And over time, the pain got worse and worse. And it spread to her neck and then to her jaw. Kelly saw all the best medical specialists that our country has to offer, and she got all the treatments available. But yet she continued to suffer with daily, severe, unrelenting pain. And on top of it, nobody could tell her why she had so much pain. And because there was no clear evidence of a structural problem, over the years people often had insinuated that her pain wasn't real, that it was all in her head, completely invalidating her experience. When I met Kelly, she was 52. That's 37 years of pain, imagine that. And no doctor could give her any hope of recovery. Her treatment was to cope with the pain as best she could. When I evaluated Kelly in my office, I confirmed for her that in fact she did not have structural cause for her pain. But I also reassured her that at least I knew that her pain was very real, something which she knew only too well. And I explained to Kelly the relationships between emotions and pain. There are several studies now showing that someone who gets an upsetting emotional event and you do a functional MRI of their brain, the parts of the brain that are activated are identical to those activated by a physical injury. This shows the mechanism by which emotional pain can cause physical pain. And we now clearly know that children who have parents that have drug problems or get divorced or are neglectful or are outright abusive, those kids have much higher rates of chronic pain and many other disorders later in life. The experience of growing up feeling unsafe sensitizes or primes that danger alarm mechanism in the brain, which can then be triggered later in life by other stressful life events or by a physical injury such as a car accident. And I've been fortunate enough to be involved in an NIH-funded research trial directed by my extraordinary colleague, Mark Lumley. In this study, we randomized 230 people with fibromyalgia, people with severe and chronic pain, but no evidence of tissue damage in the body, to 3 groups. The first group got education about fibromyalgia as a control. The second group got the very best cognitive behavioral therapy designed specifically for fibromyalgia to help them cope better with their symptoms. The third group was designed by Mark and myself. Under the influence of our colleague, Dr. Alan Abbas, we called this group Emotional Awareness and Expression Therapy. And for these folks, we offered them the chance to recognize, to experience and express, and to process powerful emotions that they had had in their life, that they may have avoided, including anger and guilt, sadness and compassion. And frankly, we weren't sure if people would engage in this kind of emotion-focused therapy. The results were striking. People at a 6-month follow-up, those in the emotional awareness group had significantly higher rates of dramatic, more than 50% pain reduction as compared to the other 2 groups. And this is the first large-scale study, to our knowledge, showing that one psychological intervention for pain is actually superior to another. So how does all this research about pain in the brain help us treat people with brain-induced or neural pathway pain? The treatment program that I outlined for Amanda and Kelly consisted of the following. The first and the most important piece, I asked them to change their mind about the source of the pain, to recognize that their real physical pain was caused by their brains and that they weren't structurally damaged, and that there was hope of recovery. And to do the hard work of calming their mind in the face of pain, to reduce fear and worry and anticipation, and to re-engage in both physical and social activities without fear, to reverse the domination that pain has over their every thought and every action. And finally, to engage in processes to deal with emotions that had occurred in their life. And as you might imagine, many people are unable or unwilling to do this kind of difficult work. But Amanda and Kelly were. How did they do? Well, they had their ups and downs. In fact, their pain got worse initially. But they held fast to the conviction that they weren't damaged, that they could retrain their brain out of pain. And little by little, they got better. And despite the predictions of experts, approximately 4 months later, both Amanda and Kelly were completely pain-free. And they've remained pain-free for the last 3 years. This is Amanda surfing in Hawaii with no back pain. This is Kelly, thoroughly enjoying time with one of her adorable grandchildren. The epidemic of chronic pain continues to grow. And the research is now very clear. A significant proportion of those folks, and I believe it's the majority, have brain-induced neural pathway pain that is very real, but not caused by structural abnormalities in the body. And for these folks, the old paradigm of pain management just doesn't fit. We have the opportunity to embrace a new paradigm that gives these folks hope for real recoveries. And if you want to learn more about this, or if you want to tell people about it, you can go to this nonprofit website, the tmswiki.org, or this 3-minute video developed by my colleague, Alan Gordon. But beware, if you tell people about these ideas, their initial reaction is likely to be disbelief or outright rejection. So please let people know with kindness and without stigma or blame. By allowing me to tell their stories, Amanda and Kelly are doing their part to change this paradigm. They're encouraging others to be open-minded enough and creative and open-minded enough and courageous enough to follow this path. But they wanted to do more. They wanted to be here today. Please join me in welcoming 2 courageous people, Amanda and Kelly to join me. This is so exciting. The three of us want to leave you with this message. The reign of pain lies mainly in the brain. Yes. Thank you. Thank you.